Hi and welcome back to Blue Light Bites. Yes, these are the mini morsels of medical education, and this edition is going to be tastier than your average Tindaloo and with much less risk of afterburn. I'm Tony. I've been an ambulance doctor, I've been a medical educator, and I've been a GP for quite a few years now. And today we are going to be talking about FND. Yes, we're going to burst the bubble of FND. Is it fact or is it fake? Well, first off, let's talk about the incidence of FND. We all know roughly what FND is, but I suspect most of us, to be honest, aren't entirely sure, and we certainly will have some misconceptions, I am sure. So FND is probably about the second commonest condition seen in a neurology clinic at this time. Some neurologists say it's more frequent than that. Headaches tends to be the first, but FND is hot on the tail of headaches. Yes, folks, it is. And it is estimated that there are about 100,000 people in the UK with a formal diagnosis of FND. That is a lot of people. That is equivalent to the whole population of Weston-super-Mare. Yes, it's saying the whole population of Weston-super-Mare has FND. Well, there's a thought. Anyway, the thing is, we have to remember that FND can happen to anyone. Yes, its typical onset age is between 20 and 40, but it can happen in children and it can happen in older people. And as far as gender goes, well, it's the ladies who get it more than the men. Yes, it's got a female prevalence of about 2 to 3 times to 1 for the chaps. Anyone can have it. It comes from all walks of life. It doesn't matter what your socio-economic status is. You are as likely as anyone else to get FND. And it's commonly associated with a number of other conditions, with anxiety, with depression, with PTSD, with fatigue, and by that I mean chronic fatigue, what we used to call ME, now chronic fatigue syndrome. It's associated with chronic pain in the form of fibromyalgia. And I see on this slide we've got chronic pain twice. So maybe there's a double association with chronic pain. It's also associated with gut issues such as IBS, and also the type of thing that causes POTS, hypermobility, EDS, Ehlers-Danlos syndrome. These all have an association with FND. Now, I've been using AI to generate images for these talks, and I can honestly say I have absolutely no idea why ChatGPT would put some penguins in this picture. But it would appear that FND is real for penguins as well as humans, and I just guess it's also a reminder that using AI is not good for the environment because it is sucking up the oceans. So hey penguins, I know you need the water. I'm truly sorry. Live and let live, I say. Now, a common conception, and to some extent a misconception of FND, is that it is associated with ACEs, that's adverse childhood experiences or adverse childhood events. In other words, emotional, physical or sexual abuse, neglect, bullying, horrible households. That certainly there is an association, but it's much more complicated than that. Recent stressful life events can also act as triggers to FND, such as losing a loved one or losing a loved relationship, or stress at work, being ill, financial difficulties, accidents, trauma. They are all quite common preceding the onset of FND. And as we said before, PTSD, anxiety and depression occur at a higher rate in people with FND than they do in the general population. However, that's not the whole story, because between 30 and 50% of patients do not have any adverse childhood experiences in their history, and it seems that FND is much more of a biopsychosocial disorder. We like that word, don't we? We say biopsychosocial because it kind of encompasses everything, and rather than having a single cause, it's probably a bit of a mishmash. It's a bit of a spaghetti of lots of different causes. Yes, a bit of a paella if you like. There's going to be a genetic susceptibility, a biological susceptibility, the way our brains function, previous illness and injury, as we've said. Pain can trigger fatigue, migraines. Psychological factors may or may not be present, and as we've said before, social and environmental influences all feed in to FND. That's a lot of F words. Let's talk about the F word, shall we, guys? Yes, ooh, here we go. We're going to talk about the F word, and the F word is functional. Yes, it is functional neurological disorder. Well, what exactly do we mean by functional? Well, functional means that it's not a physical disorder in as much that there's no problem with the actual structure of the body. There's no structural abnormality. It's to do with the way the body is functioning. And an analogy that's often used is that it is a software problem and not a hardware issue. So there's nothing physically broken, but there's something in the program which is just that little bit glitchy. And we know this because if we undertake functional MRI scanning, which is really quite rare and extraordinarily expensive but highly useful, we find out that people with FND have areas of the brain which are activated in certain situations and there are different areas to the brain that are activated in people that do not have FND. So there is a definite physiological difference, even if there is no structural difference. So that message means it's not all in their heads, at least not in a psychological way. Now, neurologists get very excited about this. Neurologists get very excited about lots of strange things. Yes, if anyone is very friendly with a neurologist or maybe even married to one, then I am truly sorry. But quite frankly, folks, they do get wrapped up in the details sometimes, don't they? And just to prove my point, here is a slide produced by a neurologist that shows what is happening in FND and how jolly interesting that all is. Extraordinarily straightforward to follow, and if you'd like to return later, then you're more than welcome to freeze on this picture and have a jolly good look. But personally, if you want to do that, I suggest you get out more into nature. Yes, join the rest of us. Get a life. Get out into the woods. Paddle your toes in the brook. Smell the pretty flowers, listen to the little birdies, feel the breeze on your face, but when smelling the little flowers, just remember, don't eat the purple ones. Okay, so I am not a neurologist. I don't want to be a neurologist. I never want to be a neurologist as long as I live. I am trying to be really good in this life so that I don't get reincarnated as a neurologist in the next life. But we are going to talk about Vikings, because that is much more my thing. Vikings are much more my thing, and we're going to do a Viking kiss. Yes, a keep it simple summary. The neuroscience of FND. Okay, so here we have a situation. We have Eric Axbeard, and we have poor old, I don't know, what should we call the little chap who's got FND and everybody's having a laugh at him? Let's call him Olaf, shall we? So Eric Axbeard gets hold of Olaf and he cleaves his head in two, which is the sort of thing Vikings used to enjoy doing. And what does he find? He finds a brain that's been cut in half. Yes, a Viking brain that looks remarkably like this one. Now, as you will see, there are three areas that are involved in FND, and all three of them have long names. So we're not going to use long names because, quite frankly, I can't remember them. So let's look at area number 3 first. That is the bit we're going to call the bottom. Yes, it's the bottom bit, and the bottom bit is an emotional centre of the brain, and it acts as an alarm system. It says, danger, 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 and it gets very excited about things that maybe the rest of us wouldn't get quite so agitated about. And then above that, there's a bit we are going to call the front bit. And the front bit just turns up the volume. Yes, it really magnifies that. So the brain is screaming, danger, 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 although that bit can be distracted. And then there's a bit on the side. I don't know if we should call it a bit on the side. Shall we call it a bit on the side nearer the back? Yes, the bit on the side nearer the back. Well, that is where the fun and games really happen, because that is where motor and sensory pathways get into all sorts of a jumble, a little bit of a tangle. Now, what triggers FND? What triggers? Well, the specific triggers for specific episodes tend to be things like high stress situations, lots of anxiety, when you're emotionally overwhelmed by a situation or emotionally traumatized, low mood, depression, failing to buy Batteries that last, yes, you should have gone for Duracell. So physical exhaustion or lack of sleep, they sap your batteries, they can trigger FND. Pain can, acute pain can, chronic pain can, illness can, sensory overload like lights and noise and crowds, which is why I stay away from nightclubs and instead I rock gently in a dark room. Having deadlines and time pressures can be a trigger, as can relationship problems, conflicts with other people, big life changes or life uncertainties, particularly if you feel unheard or unsafe or not understood. So these are the triggers. So what is happening in poor Olaf's brain? Well, normally, if Olaf didn't have FND, you'd have a lovely two-way traffic. Yes, you would have sensory impulses coming from the body going up into the brain, and the brain would then be sending motor impulses down to the body. Now, the sensory information would be telling the brain what is happening, and the motor information is telling the body what it wants to happen, and they work in a lovely little loop, and everybody gets on well and function as normal. But here's the thing, folks, in FND, things go wrong. Yes, the sensory road becomes blocked. Sensory impulses do not transmit in the normal way to the brain. And because of that, well, frankly, Valhalla breaks loose. Yes, it becomes a freeway. It becomes a total motor impulse rampage. They run riot. They do all sorts of weird stuff. The body does an awful lot of strange things. Here are some of the things it can do. Seizures, that's what we think of most, isn't it? Seizures, they're called dissociative seizures. They're called a lot of other things as well. More on that in a moment. There can be weakness. There can be paralysis that mimics a stroke. Patients can have difficulties with their movement. They can have gait problems, balance problems. They can have changes in their voice. They can have changes in their speech. They can get all tremulous and shaky. And they can also have bladder and bowel dysfunctions. And they can also get sensory problems, sensory symptoms, strange, weird, wonderful sensory symptoms. And they can get pain, and they can get abnormal visual symptoms. And then one of the things is these symptoms tend to fluctuate. The pattern can vary within an individual between episodes. And the pattern can also vary within an individual during a single episode. So there is a marked fluctuation in symptoms. Not always, but sometimes. Okay, so it's time to say goodbye to the Vikings. We'll be seeing you guys. And now it's time to talk about actual presentations of FND that we might encounter either in the emergency operations centre, so in the clinical support desk when we're talking to patients, or when we're out on the road. And by far the most common is going to be this one, isn't it? It's going to be seizures. Now, FND seizures are known by many names. They're known by NEAD, that's non-epileptic attack disorder. They're called non-epileptic seizures. They're called psychogenic non-epileptic seizures, PNES. They're called psychogenic seizures, functional seizures, dissociative seizures, but we mustn't be calling them pseudo seizures. Why? Because they are not pseudo, guys. These are real. So how do we tell them apart? How do we tell an FND seizure from an actual epilepsy seizure? And one word of caution at this point, probably about 10% of people who suffer with FND also have epilepsy, so tread with caution. Right, let's look at onset. Onset first. Epileptic seizures, proper job epileptic seizures, often come on very suddenly, whereas in FND it tends to be a more gradual onset, and the symptoms can wax and they can wane, they can come and they can go. Injury patterns. In epilepsy, as we all know, injury is common, particularly tongue biting, and particularly biting the lateral sides of the tongue, the edges of the tongue. And the patients may be incontinent and they may fall to the ground and they may injure themselves quite significantly. Whereas in FND, injury is less common. It can still occur, but it is less common. And if they bite their tongue, well, it tends to be the tip of the tongue rather than the sides. And it's rare, but not unheard of, that they are incontinent. What about the movement patterns? Well, in true epilepsy, movements tend to be stiff and jerky, they're symmetrical and they're rhythmic. and typically eyes will be open. In FND, movements are different. They often are floppy, sort of thrashing movements. They're often asynchronous, and the head can move from side to side, and the eyes are often closed or they're blinking. And looking at that picture, they also get 3 arms. Well, that's interesting, isn't it? I've just noticed that lady has 3 arms. Well, that's an obvious sign of FND, guys. If you find a patient with 3 arms all waving at you, you've got your diagnosis. The other thing that can happen is pelvic thrusting. Yes, pelvic thrusting appears to be a feature of FND. Now, I thought I'd look for a nice image of pelvic thrusting, but believe me, friends, do not Google search pelvic thrusting. We'll move on quickly. Okay, so duration. Epileptic seizures typically short, 1 to 2 minutes, maybe a little bit longer. Obviously in status, well, that's a little bit of a different kettle of fish, but in a normal epileptic seizure, they're short duration, whereas in FND, they're often much longer than that. They're persistent, or they wax and wane. They get intense and then they settle, then they get intense and then they settle again. And then after the episode, well, as we know, in epilepsy, confusion, drowsiness, headache, aches are all really common, and recovery time tends to be often in the region of 20 to 30 minutes, whereas in FND, well, they tend to return to normality much more quickly. True seizures can occur when the patient is alone or asleep, whereas functional seizures often occur when they are with other people. Now, one thing about true epilepsy is that the seizure activity is not influenced by bystanders, but in FND it can be. That bit of the brain at the front can be distracted. Now we're talking about EEGs at the bottom of this slide. I didn't ask for that, but it's a little bit extra. So here we go. If the patient were in hospital with epilepsy, even after the event, they would probably have, not always, but probably have an abnormal EEG. Whereas in FND, the EEG would be normal during and after. Although, quite frankly, looking at that picture and the bottom right there, that doesn't look very healthy to me. And if it's an ECG, it's certainly time to check leads and gain or commence CPR. Right, let's think about this. Now, what do we do? What do we do? Well, listen, guys, no matter how long the seizure has been going on for, the good news is that functional seizures do not harm the brain, okay? They do not cause hypoxia. They do not cause brain damage. They do not cause the havoc that normal epileptic seizures do. Oxygen saturations may drop, but they'll only be very briefly reduced, and that's because patients tend to ventilate much better in an FND seizure than they do in a true epileptic seizure. I'm using the word true here. I'm very aware I'm using the word true. I don't know how else to distinguish it. True makes it sound like the FND is false. It is not false, but you know what I mean. Okay. Patients in FND, they may look cyanosed and they may breath hold, but it will be transient. It will be transient. They're not going to have that prolonged or relatively prolonged tonic episode before a tonic-clonic seizure. So the good news is they are not harming the brain. It doesn't matter how long they're going on for, they are not harming the brain, and therefore we don't have to get too excited by them, do we? We don't have to get too worried, but we want to worry, don't we? Because we don't like people having seizures in front of us, particularly in Sainsbury's. Why? Well, it looks a bit messy for a start, and people are looking at you and they're wondering why you're not doing anything. And you've got a bag load of stuff there and you just want to stick it in the patient, don't you? You want to do something to stop the seizure. And just to make matters worse, Karen is getting a little bit narky because she can't reach the nachos on the shelf above the patient. So you want to do something, but there's nothing to do. There's nothing physical to do in terms of drug therapy. But what you can do, or better still, let's say what you can't do, is do what I have to admit I have been guilty of doing in the past. And that's basically saying, okay, you can stop now. It's okay. We know it's not a real seizure. Just stop. Well, for everybody I've said that in the past, I am humbly sorry. I repent of my sins. I suspect I'm not the only one guilty of this transgression. So guys, it's not all in the head. Don't tell the patient to stop faking it. Don't tell them they're wasting your time, because it's a lot more complicated than that. But what you can do in an FND seizure is calm it all down. There will be a lot of anxiety often, particularly in a public place. There'll be anxiety if family aren't used to seeing the patient having these seizures. So stay calm. It'll reduce the distress of the patient. It'll reduce everybody else's distress. Make sure that the patient is kept safe, just like you would in any other seizure, and be calm and reassuring and positive in your tone. Obviously, don't hold them down. Try and reduce stimulation, lower the noise, limit the crowd, make the space as quiet as possible. Reassure the patient. Say, we understand what's happening. It's not dangerous. It's going to get better. And remember, you can distract them. You can distract them maybe by gently encourage their breathing, or get them to focus on something like, squeeze my hand, squeeze my hand, squeeze my hand. And be patient with them. These seizures may last quite a long time. You need to be patient, and obviously treat the patient with respect and dignity. That goes without saying, doesn't it? So that's seizures. That is seizures. Let's talk about the other common, not as common, but quite common presentation of FND, and that is motor problems that resemble strokes. Yes, things that look like strokes, things that turn arms to jelly. So does this patient have a stroke or FND? Here are a few ways you can tell the difference. Once again, strokes tend to be, not always, but tend to be sudden onset. And FND, well, it tends to be gradual onset. Symptoms can come and go. And the symptom pattern in FND is a little bit bizarre. It's not like a stroke when it's a typical sort of stroke pattern. Often it's a facial weakness, arm weakness, leg weakness, typically on one side. Whereas an FND, it doesn't really fit any pattern at all, and symptoms can change. And things that aren't even anatomically possible may be part of the presentation. And it also can be inconsistent. So they might have a wrist drop, showing weakness at that point, but they can still lift their arms, which you wouldn't expect in a true stroke. They may have a positive Hoover's sign. I'm not going to go into Hoover's sign. If you want to look it up, then crack on. You look it up or Hoover it up. Do whatever you like. Other neurological symptoms. So in a stroke, obviously facial weakness, speech problems, visual loss, whereas associated signs in FND tend to be less typical, and they're often inconsistent and may vary during the course of the episode. On examination, as we said, the signs of a person with a stroke are consistent, and they can't really be explained by another neurological condition. Whereas in FND, they may well change during the examination, or they may be different if we retest them. Now, the next slide goes on to talk about CT and MRI. Well, we're not actually going to do that, but the other thing to think about is risk factors. Now, here's another place where you can really fall into bandit country, because typically your stroke patient will have vascular risk factors like high blood pressure, diabetes, AF, smoking, whereas people with FND typically will have stress, maybe some psychological trauma, anxiety, that type of thing. But obviously it goes without saying that there's an awful lot of cross-fertilization here. Yes, risk factors can be just as problematical in people with FND. Stroke patients can look unwell. They don't have to, do they? But they can look unwell, whereas an FND patients normally look pretty chipper. So there you go. That a little bit of a discussion there about what FND is, what FND isn't. We've talked about the presentation of seizures, and we've talked about presentations that resemble strokes. So what are the key factors? What are the key messages we can take away? Well, the biggest message, folks, is FND is real, okay? It's not all in the patient's head. They're not putting it on. They don't want it any more than you want to be there with them when they have it. It's commoner than you think. There are, as we said, probably up to 100,000 people with diagnosed FND in Western-super-Mare and indeed in the UK at this time. But it probably affects much more than that. There are probably maybe 1 in 20 people have some sort of FND. But the good news is there is hope. FND isn't necessarily a lifelong condition. It can be helped. It can be helped by a diagnosis which is a positive diagnosis, and that can only be made by a neurologist. And I think it's very important at this point to say if this is a first seizure, they're going to hospital, whatever. Even if you think it's FND, don't mess with it, they're going to hospital. Similarly, if it's stroke-like symptoms, they're not known to have FND, then they are going to hospital. Okay, but having got a positive diagnosis, then these patients can be helped. They can be helped by lots and lots of things that end with the word therapy. Yes, they can be helped by psychotherapy, physiotherapy, occupational therapy, all sorts of therapies, and they can get better. So I guess the final message is it's nobody's fault. It is certainly not the patient's fault. It's not being faked. It can happen to anyone, and we shouldn't be judgmental. And then that picture number 8, I love that. It says believe, understand, support, because together we can make a difference. Isn't that lovely? Isn't that pink and fluffy? Wouldn't that be a lovely way for the world to live? Oh, and I'm on, which means we must have got to the end. This is the end of our talk on FND. I hope it's been enlightening. I hope it's been useful. I have to say I've learned quite a lot and been rather humbled at times during the research for this episode of Blue Light Bites. I'm going to be back again next month, which is going to be, where are we? September. September, we are going to be back, and I think we're going to talk about electrical injuries. Now, that sounds pretty straightforward, and I'm sure you think you know all about it, but actually, when do patients need to be seen in a hospital? Do they need to go to hospital? Can they be safely discharged at home? Can you advise over the phone for a patient to go to A&E? Lots and lots of questions to ask, and hopefully I'll be providing you with lots and lots of answers. But until then, guys, if you're having a summer holiday, have a really blessed one. Stay safe, be happy, keep the faith, and don't forget to share the love, share the learning, and share the link. I'll see you in September. Bye for now.